This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome, everybody, to PHM from Pittsburgh, our special Journal Club series episodes here on PHM from Pittsburgh. For those of you who are new, we're a continuing medical education podcast, which was started in October of 2016, which is now getting farther and farther away, here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. Now, we've been coming to you discussing different topics on the American Board of Pediatrics content specifications for initially pediatric hospital medicine, and then some contemporary stuff that's come up that's demanded attention, like our favorite virus and yours, COVID. But one of the areas we were trying to figure out how to cover is this research part of the content specifications. This is where you learn, or we learn, how to critically evaluate the literature. Now, you got to assume and imagine this is going to be really hard to do in an audio-only podcast format. But by George, we're going to give it a shot. So now to pull this off, we've partnered with our colleagues at Dell Children's Medical Center, Dr. Philana Lin, who is our own University of Pittsburgh infectious disease specialist, and our expert colleagues at the University of Texas at Austin. And so you're going to meet a bunch of them throughout this series. And today we have one of our colleagues from Texas with us now. So today we're going to talk about statistical power. We have with us Dr. Matthew Wilkinson to help with this. Dr. Wilkinson is an associate professor and pediatric emergency medicine faculty in the Department of Pediatrics at the University of Texas Dell Medical School. He received his BA from Harvard University, MD from the University of Connecticut, and MPH in biostatistics from the University of Texas. He's published 20 recent articles as a first or senior author on a wide variety of topics related to the care of sick and injured children. He's the research director for the Pediatric Emergency Medicine Fellowship Program and the assistant chair of clinical research in the Department of Pediatrics. He's responsible for the education and mentorship of trainees and faculty of all levels in the Department of Pediatrics, focusing on topics related to research methodology, biostatistics, and evidence-based practice. So we are very fortunate and very privileged to have Dr. Wilkinson. Dr. Wilkinson, thank you for joining us.
Tony, thank you so much for this opportunity. I'm very excited.
Now, when most people hear of the possibility of talking about statistical power, they may not be excited, but we should be. Let's do our disclosure statements. Matt, I will start and I'll kick it out to you. I am disclosing that I was on, for the Sanofi Corporation, the 2022 meningococcal vaccine immunocompromised advisory board, which should have no bearing on what we're talking about today.
And I am a board member and stock owner of a medical device company called EM Device Lab. And once again, we will not be discussing anything related to that relationship.
Before we talk about this, just so those of you who are following along, these episodes are shorter than we normally have, and we're going to use an article that we're going to reference and which we've been using throughout these Journal Club episodes. The article we're using, so you can get it up if you want to, is by Courtney A., Bernard A., Burgess S. et al., called Bolus versus Continuous Nasogastric Feeds, Infants with Bronchiolitis, a Randomized Trial. This was in Hospital Pediatrics, Volume 12, Issue 1, January 2022. And Matt, do you want me to quickly summarize the article for people?
Sure, that's fantastic. Thank you.
So we have talked about this study before, our Australian colleagues who do great work, but just to refresh your memory, it was a study comparing continuous versus bolus NG feeding for infants hospitalized with bronchiolitis. Their primary hypothesis was that continuous NG feeding would result in an increased length of stay when compared with bolus NG feeding. Some of its specifics: it was a randomized parallel group superiority clinical trial performed in Australian children's hospitals through 2 bronchiolitis seasons from May 2018 and October 2019. Infants less than 12 months old hospitalized with bronchiolitis and requiring supplemental nasogastric feeding were randomly assigned to continuous or bolus, and length of stay was the primary outcome. Secondary outcome measures included pulmonary aspiration and admission to the intensive care. Now, Matt, I am not great with statistical power, so I'm excited to learn.
That's fantastic. So, Tony, let me start with saying that I am very excited about all things statistics, as all my colleagues and fellows know, for better or worse. So I really enjoy talking about these topics, especially with people that want to learn about statistics. I think it's something that, we are taught and are generally very uncomfortable with. You may have been taught these concepts in medical school and not seen them again. And then you're expected to recall this very specific information when, reviewing articles or having discussions related to evidence-based medicine. And I find that most clinicians, and, pediatric emergency medicine is a very clinical subspecialty. It is becoming more academic, and we are expected to do research, but these are mostly clinicians that I'm dealing with in training. And so they start off very uncomfortable with these topics, and I try to make it relatable when I do, lectures and discussions and lead journal clubs, and try to get as much as possible away from the math of it, which is what I think people find the most scary or unapproachable, and try to make it just more relatable and more about concepts. Jump right into talking about statistical power, if that's something you're interested in.
Yeah, let's do it.
So I think, unfortunately, in order to talk about power, like with all statistical concepts, you do need some baseline information, definitions, some Greek letters, unfortunately, to have an intelligent conversation. And like you stated, sometimes that's difficult with audio only, but I'll do my best. And so, in a very broad sense, statistical power, means what is the ability of this study to find some relationship, some difference, some association in the sample, if that association or difference truly exists in the population. That's kind of broadly speaking what power is. So if there is an association, if there is a difference, based on the way I have set up my study, set up my sample size, set up my sampling technique, what is the probability that I'm going to find a difference if a difference really does exist in the world, in the population? And so that's what we're talking about with statistical power. And there are definitions, like I said, that we sort of need to understand to talk more intelligently about it. And so I think everybody has heard of alpha, has heard of beta, has heard of effect sizes, has heard of standard deviations, proportions. And those are all the things that go into the discussion about statistical power. And there will often be a section in a paper, and this paper has that section, the one we're talking about right now, labeled as sample size, that will talk about the derivation of the sample size for this study, and often use those terms to kind of help the reader understand how they did the math, how the computer spit out a sample size with the appropriate alpha, beta, effect size, and standard deviation. So just going back to define those different variables. So alpha is the probability of making a type 1 error. So what does that mean? So it is the probability of finding a difference or an association in the study that doesn't exist in the population. So you made a mistake. You found something that looked real and it wasn't. So it turned out you should not have rejected the null hypothesis in favor of this alternative hypothesis, but by pure random chance in your sample, you sampled that population in a way that gave you a mathematical result that looked like there was an association. So that's a type 1 error. That's alpha. That number is set by the researcher. And so that's very important. You decide what you want your type 1 error rate to be when you design a trial. So in clinical medicine, it's very, very common to see an alpha of 0.05. And so what that means is there's a 5% chance of finding a result in your sample that looks like it's real and it's not. It's by pure just statistical accident. And we set it at 5% because in general, type 1 errors are thought to be more dangerous than type 2 errors. So if you make a type 1 error and you publish a result and it looks like there is a new finding, that can change practice. And changing practice from the standard of care is thought to be risky or dangerous. And so we don't want to make a lot of type 1 errors and publish them and have folks change practice when in reality, this new therapy or this association is not real. And so it's typically set around 5%. It could be set anywhere. It could be set at 1%. So if you're doing a study that's maybe involving something very risky, you can set the alpha lower than that. You can set it at 1% because we don't want to publish these results unless we're absolutely sure that this association is real. So the researcher decides where the alpha gets set. That's your type 1 error rate. And then at the end of the study, if we're using p-values, and it's a whole different discussion about p-values, but this study uses p-values. If your p-value at the end of the study is less than your preset alpha, then we designate that there isn't a true association. There is a difference. We reject the null hypothesis, and this is called a positive study with a positive result. So that's kind of a big deal. And so that's alpha. What else goes into your sample size determination? So beta. What is beta? Beta is your type 2 error rate. What is a type 2 error? That is incorrectly concluding that the null hypothesis is true. And so you fail to reject the null in favor of the alternative. You incorrectly assume that there is no association, when in reality, in the population, there actually is an association or there is a difference. And so you made a mistake thinking that the two things were equal. There is no association. In reality, in the population, there actually is. It's just by pure sampling error, you missed it. You missed the association that you wanted to find. So those are typically set at about 0.1 or 0.2 is the beta, the type 2 error rate. So you'll most frequently see 0.2 or 20%. Power is simply 1 minus beta. So the power of the study is basically what is the probability of finding that result if it's there? Well, 1 minus your beta, 1 minus your type 2 error rate. So if you set your beta at 0.2, your power is 80%, which tells you that, if you run this trial 100 times with all the same parameters, 80 of those times, if there's a difference, you're going to find it. 20 times by pure random chance, you won't find it. So the researchers need to decide what type 2 error rate are they going to accept, and that's your beta. And again, there's lots of other factors that will go into that. So if you're doing a big expensive trial, and this is the only trial your company's ever going to do, you might set that beta lower because, if there's a difference, you really want to find it. You don't ever want to do this trial again. We're going to do it one time. We're going to set our beta lower at 0.1 to make sure that if there is something there, we find it. So that's beta and that's power. Now, the other things that go into your sample size determination besides alpha and beta, it depends a little bit on what your outcome variable is. And so referring back to the study, the outcome variable, length of stay, is a continuous variable. So the primary outcome variable for this study, length of stay, is what's called a continuous variable. So it can take on essentially any value as opposed to a proportion, which would be a different type of endpoint variable. So when dealing with continuous variables as an endpoint, there is another measure we care about besides, the means of the groups. We also care about a measure of how the variable spreads out in both the sample and the population. And so that measure, the most common measure you'll see, is the standard deviation, which is simply the square root of the variance. And so when trying to determine a sample size or the power of a study, we need to know for a continuous endpoint, what is the expected effect size? So what difference are we expected to find in the means of the two populations? But that's not the only thing that matters when calculating power or sample size. We also care about a measure of spread, which is usually the standard deviation. And so if two populations, and so, in this study, it would be folks getting continuous feeds versus bolus feeds. So if all of those kids in each group stayed for an amount of hours that is very similar to each other, so the data doesn't spread out very much. They're all kind of staying about the same amount of time in each group. There may be a difference between the groups, but everyone within a group is staying pretty much about the same amount of time. It would have a small standard deviation, and those differences would be much easier to find because they're not overlapping each other. These two populations are very distinct, so they're not very spread out. And so statistically, those differences are easier to find. If the children within each group are very dissimilar, and so some would stay for 10 hours, some would stay for 300 hours, and they're all over the place. You can imagine that even if the intervention did provide a difference, it's much harder to find mathematically because there's so much overlap between the groups because they're so spread out. And so that is the reason why in a sample size calculation, we care about not only the expected difference, but also the standard deviation and how much overlap there is between the groups. And so if you look at a sample size formula, which I won't make anybody here do because your head will probably explode, the things that go into it are alpha, beta, standard deviation, and then effect size, which is the expected difference between the groups. And so once you have all that, you have everything you need to do a sample size calculation. And the power of this study, if it turns out the way you expect, is basically 1 minus beta that the author set up. And so in this study, they went with a power of 80%. So if there was an expected difference of 24 hours, so if the difference between the two groups were 24 hours in reality, in the population, in real life, with the standard deviation that they proposed, they had an 80% chance of finding that difference if that difference existed, if that makes sense.
So can I ask if you need the spread of the populations or whether it's, I guess, randomly, whether it's a normal distribution, how would you get that prior to doing the study? Because shouldn't you calculate this before you do a study?
Fantastic question, Tony. So there's a number of ways to get that information. Some sites will do pilot data, which honestly is probably the most accurate way of doing it. So you enroll 20, 30, 40 subjects before you officially start your trial. And sometimes those subjects can be included in the trial. And then you use that sample to try and decide, okay, what is the true baseline mean length of stay? And what is the true baseline standard deviation in this group? And that's more accurate because it's the actual population that you're going to be sampling from. So if they had done this in their emergency department in Australia, this group of people that are treated this way by this hospital, they probably would have gotten a very accurate baseline mean and standard deviation for length of stay. The other way to do it, which is more common, which is what was done here, is to pull it from prior literature. And so they used a prior study for a different purpose. And so that's important in a slightly different population because it was multi-center. It wasn't in the same country. But you can imagine that the length of stay, once you start pulling from other hospitals, and I believe this was an international study, so probably some other countries as well, you can imagine that mean length of stay and that standard deviation is going to be a little bit different, probably because of all kinds of factors extrinsic to the current study. And so the accuracy of your baseline values for your sample size calculation are very, very important, because if in your sample, in your population, those aren't accurate, all of your calculations will be off. And so the power you think you had may not be the power you actually had when you conducted your study. And so we saw that in this study because they were using baseline length of stays for their calculation and standard deviations for their calculation that are not what they found in their study. And sometimes what you'll see people do, and I usually advocate for this, and sometimes it's required in FDA trials, is a retrospective power calculation where you, especially when you have a negative result like this, you take your actual means and standard deviations, go backwards and say, looking for a 24-hour difference with what we actually found for mean and standard deviation, our power was actually this. And it looks like their standard deviation is much smaller than what was in their sample size calculation. So their power actually was probably a little bit higher to find a 24-hour difference. 24 hours is a really big difference with the standard deviations that are in this study. And so that a whole separate discussion and argument can be about, was the effect size that they were looking for too large? And that's why they had a negative result. And all that matters. And this is part of why when I do journal clubs and teach evidence-based medicine, we really, really focus on the methods. And you'll hear this over and over again. The methods are everything. People want to read the abstract. They want to look at the results. They want to look at the author's conclusions and kind of skip the really, really important stuff. Because simply saying that this is a negative study because they did not find a difference in length of stay while ignoring their underlying assumptions for their sample size calculation, I think is kind of doing everybody a disservice. Because you do need to ask yourself, and they put this a little bit in their limitations, and they said, a larger sample size would have allowed us to look for a 12-hour difference. And For those of us that do clinical medicine, a 12-hour difference probably matters, and it matters to the family. It matters to the patients. It matters
Yeah.
to the folks taking care of them. And so these are all decisions that are made by the authors. And I've had to make these decisions, and you just have to live with them on the back end because people are going to disagree with you. And that's just part of the deal. But I think for trainees, what's important is understanding the decisions that are made and then the impact it can have on the interpretation of the results.
And then going back to beta, it's funny when you don't know about statistics like I do. You assume things like beta are like forces of nature, like water is wet, grass is green. Beta is a known thing that you can easily calculate, but it sounds like it's more chosen. You can decide you want, like you were saying, a more stringent beta, 0.1 or 10%, because you really want to see that you found the difference if it's there, or you can be wider. And I'm assuming you would dictate that based on how many patients you have, what you're doing, and what you want to do with the data. So if someone gave you a beta of 50% and you were reading that paper and judging it for a journal, you'd probably say, that's crazy. That's too high. Is that fair?
That's exactly right, Tony. And I think a follow-up question would be, okay, if we don't want to make type 1 or type 2 errors, why don't we make the alpha and the beta as small as possible, right? Why do we want to ever have a chance of making a mistake? Well, what do you think happens when you make alpha very small and beta very small? The sample size goes through the roof. And so these are very real considerations. And, having done this for many, many trials, the reality is you sometimes have to play with the numbers a little bit and make decisions about the reality of that study design and whether or not that population is achievable given, the constraints that you're under, whether they be time constraints for trainees or financial constraints, because every enrollment costs money. So in a perfect world, you would make alpha as close to zero and beta as close to zero as possible. But if you, use an online program and start dropping alpha and beta and look at what happens with the sample size, it sort of goes exponentially through the roof and just makes a study not feasible. So there's very real world considerations. And, there's these generally accepted practices of alpha of 0.05 and a beta of 0.2. And so that's often what you'll see people stick with. And then, if you're stuck with that and you're kind of stuck with a sample size. So if you fix sample size and you fix alpha and beta, the only thing you have left to play with is your effect size. And so oftentimes when you're dealing with studies with a fixed alpha beta, they know they're only going to be able to enroll, say, 200 subjects. The only thing left to change there is the effect size. And sometimes you'll see effect sizes that seem odd. You'll find weird numbers that don't make a lot of sense. And that's often how that ends up happening, is because they're constrained by everything else. And the only thing left to vary is the effect size.
I can imagine if you're dealing with a rare disease or condition, you have to, because there's not that many patients who have a rare condition X, Y, or Z.
Yeah, especially for this type of study design, rare conditions are better studied, at least early on, with, retrospective cohorts or case control studies. And that's the entire reason why things are studied that way. If you have a very uncommon outcome, doing a cohort study or an RCT is just going to be incredibly expensive. And those ends are very, very high. And so that's why you see different types of study designs for those outcomes.
This has been Aya. Would you mind reading the definition you have of statistical power one more time for our listeners?
Well, I didn't have it written down, but here, let's go. Let's see if I can recreate it. So the power of a study is the probability of finding an actual difference or association that exists in the population, given your parameters you set up in your study, alpha, effect size, and your sampling design. It is the probability of finding a difference or association if that difference or association exists.
That is fantastic. This has been very helpful. I mean, as it's clear, I am not the best statistician, and so that's the perfect person to host these episodes, because I'm going to literally learn as we go along. So this was great. Is there anything we didn't talk about, Matt, that we should have?
I think we covered almost everything. There are some other interesting aspects of this study that are maybe too advanced for this conversation, but I think we covered the important stuff.
That's great. Thank you. Listen, thank you so much for being on the show and walking us through statistical power. This was an episode I was worried about because I didn't feel comfortable with it, and I feel better about it now. Thank you.
Thank you so much for having me. I really appreciate it.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guests for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always, thank you for listening!